Welcome to our clinical case study titled The After Dinner Dip. As you can see on the title screen, we are going to explore a fascinating clinical challenge involving an 85-year-old woman who presents with recurrent postprandial spells and a general constitutional decline. Notice the subtitle here, which highlights our unique approach today. We will be walking through a staged journey of medical logic featuring me, the user, interacting with three different large language models acting in various clinical roles. This multi agent synthesis will help us unpack the diagnostic reasoning step by step. We will see how different artificial intelligence perspectives can challenge our assumptions and refine our clinical thinking when faced with a complex, evolving patient presentation. Let us look at the specific goals we aim to achieve during this session. Looking at the two columns on this screen, you can see our core learning objectives divided into clinical reasoning and diagnostic precision. On the left, our clinical goals are to evaluate postprandial syncope in an elderly patient, understand how to interpret critical samples during hypoglycemia, and identify the specific triggers of autoimmune insulin disorders. Moving to the right column, our diagnostic goals focus on differentiating an insulinoma from antibody mediated syndromes. We also want to synthesize metabolic findings with constitutional symptoms like weight loss and crucially avoid premature closure and over-imaging. These objectives will guide our evaluation as we navigate the nuances of this patient's presentation. To understand how we will tackle these goals, we should review the structure of our multi-agent discussion. Notice the format outlined in the two panels here. We are using a multi-agent orchestration to simulate a real medical team. The left panel details the roles: a resident providing initial analysis, an attending offering critique and Bayesian refinement, and an expert delivering the unifying diagnosis and teaching pearls. The right panel explains our process. The case will be revealed in sequential stages with the progressive release of data. This allows for an iterative refinement of our diagnostic hypotheses, mirroring how a real clinical scenario unfolds in the hospital. By structuring the conversation this way, we can see how initial broad differentials are systematically narrowed down. Now we are ready to dive into the patient's initial presentation at the emergency department. As you can see in the left panel, our patient is an 85-year-old woman brought to the hospital after a loss of consciousness. This event occurred exactly 45 minutes after dinner. She experienced a distinct prodrome of sweating, palpitations, and feeling cold. Notably, she has had 3 similar, though milder, episodes over the past 2 weeks. Shifting to the right panel, her history reveals no chest pain, shortness of breath, or incontinence. However, she does report recent headaches over the last few days and an unintentional weight loss of 2 to 3 kilograms over a few months. This combination of a highly specific post-meal timing and generalized decline requires careful interpretation. Let us pause for a moment to consider how we should frame this initial data. Looking at the 3 questions stacked on this screen, we need to establish our primary diagnostic frame. The first box asks whether this is fundamentally a metabolic, cardiovascular, or neurological event. A sudden loss of consciousness in an elderly patient often points to the heart or brain, but the prodrome suggests otherwise. The second box highlights the 45-minute post-meal timing. How does that specific window influence your thinking? It strongly pulls us toward a metabolic or digestive trigger. Finally, the third box questions the significance of her weight loss. In an 85-year-old, does a 2 to 3 kilogram drop shift our priority toward an underlying malignancy? These are the exact questions our simulated medical team must grapple with as they begin their analysis. Notice the 3 columns here displaying our team's initial reasoning. On the far left, the resident suggests reactive hypoglycemia, an insulinoma, or a pheochromocytoma, recommending bedside glucose and metanephrine testing. In the middle column, the attending critiques this as jumping the gun on rare tumors. They emphasize that postprandial syncope in an elderly patient is cardiac until proven otherwise, prioritizing an electrocardiogram and orthostatic vitals. However, the expert in the right column synthesizes the clues differently. They point out that the stereotyped autonomic prodrome strongly suggest hypoglycemia, and the loss of consciousness reflects neuroglycopenia. The expert's clear mandate is to document Whipple's triad during an active episode. We will soon see which of these clinical perspectives aligns with the data from the emergency medical services. As you can see in the left panel, detailing the emergency arrival, the patient's vital signs were relatively stable with a blood pressure of 135/65 and a heart rate of 78. She was still unconscious, though her pupils were reactive and cardiopulmonary exams were normal. The critical breakthrough appears in the right panel under the intervention. A random blood sugar check revealed a dangerously low level of 40 milligrams per deciliter. The medics immediately administered 100 milliliters of 10% intravenous glucose. Following this treatment, the patient promptly regained consciousness. This sequence of events perfectly satisfies the expert's mandate from our previous discussion. Let us examine how our medical team interprets this undeniable proof of a low blood sugar event. Looking at the three columns on this slide, our team adjusts to the new evidence. The resident on the left notes that Whipple's triad is now confirmed, shifting the leading suspects to an insulinoma or non-insulinoma pancreatogenous hypoglycemia syndrome. They rightly request a critical sample during the next drop. The attending in the center adds a crucial safety check, insisting we must immediately rule out the use of exogenous secretagogues like diabetic medications. On the right, the expert highlights a fundamental pivot in our clinical framing. We are no longer working up a generic case of syncope. We are now dealing with documented hypoglycemia. The core question shifts entirely from why she fainted to why her blood sugar is dropping. We need more background information to answer that question. Notice the personal history details on the left side of the screen. We learn the patient is of Eritrean descent and emigrated just 2 weeks ago. She has no history of diabetes mellitus, does not smoke or drink, and has no family history of autoimmune diseases. Moving to the right panel, we see her current status. Her only medication is a combination of triamterene and hydrochlorothiazide for blood pressure. On examination, she is well appearing and alert, with a normal body mass index of 22, and she has no neurological deficits or skin changes. This specific combination of a recent emigration and a seemingly benign medication list provides hidden clues. Let us see how the simulated team connects her demographic background to her medication profile. As you can see in the residence column on the left, there is a brilliant pivot here. They suggest insulin autoimmune syndrome, also known as Hirata disease, noting that it can be triggered by medications containing sulfhydryl groups like her thiazide diuretic. So, the attending in the middle agrees to stop the thiazide but adds a practical layer, advising a screen for malaria or tuberculosis, given her recent emigration and unexplained weight loss. The expert on the right synthesizes this perfectly. They emphasize that strictly postprandial episodes in a non-diabetic patient strongly favor insulin autoimmune syndrome over an insulinoma. They advise considering this syndrome before aggressively hunting for a pancreatic tumor. With these hypotheses established, we must look at the results of her initial hospital workup. Looking at the initial labs panel on the left, the results are mostly unremarkable. Her hemoglobin A1C is 5.5%, confirming she does not have underlying diabetes. Her liver and kidney function tests are normal, aside from a mild hyponatremia with a sodium level of 130 millimoles per liter. Inflammatory markers like C-reactive protein are low, and her thyroid function is completely normal. The right panel notes her clinical stability. She has been admitted for close observation, but a major mystery remains. Her reported weight loss and recent headaches are entirely unexplained by these basic baseline laboratory tests. To figure out what is truly driving her condition, we need to observe what happens while she is monitored on the inpatient ward. Notice the alarming data in the left panel detailing her recurrent drop. Despite oral food intake, her blood sugar plummeted to 35 milligrams per deciliter. This required a heavy intervention of 40% intravenous glucose. Strikingly, her blood sugar rebounded to 193 milligrams per deciliter within just 1 hour. The right panel shows the endocrine checks performed during this volatility. A standard 5% dextrose infusion failed to maintain her levels, forcing an escalation to a highly concentrated 20% dextrose infusion. Additionally, a corticotropin test returned normal results, which definitely rules out adrenal insufficiency as the cause. This extreme swinging of blood sugar levels is a major red flag. Let us see how the clinical team interprets this highly refractory and volatile pattern. Looking at the three columns on this slide, the team grapples with the severe inpatient recurrence. The resident on the left notes persistent hyperinsulinism, stating that the brittle, volatile nature of her blood sugars heavily favors insulin autoimmune syndrome. In the middle, the attending raises a critical management concern. Pumping 20% dextrose into an 85-year-old is excessive fluid management. So, they advise securing central venous access and strictly counting carbohydrates. The expert on the right provides the definitive diagnostic takeaway. The fact that severe hypoglycemia is recurring despite a continuous infusion of dextrose completely rules out simple starvation or adrenal failure. This means her body is actively and inappropriately secreting massive amounts of insulin. We finally managed to draw the right labs during one of these crashes. As you can see in the left panel, we finally captured the critical sample during loss of consciousness. The numbers here are the smoking gun. Her glucose was a critically low 16.2 milligrams per deciliter. Simultaneously, her insulin was sky high at 182 microunits per milliliter, accompanied by an inappropriately high C peptide of 2.0 nanograms per milliliter. Moving to the right panel, the imaging search yielded surprising results. Comprehensive scans of her pancreas showed absolutely no mass, and her sulfonylurea screen was negative, ruling out secretagogue abuse. However, there was a completely unexpected incidental finding. A suspicious lesion was discovered in her left breast. This combination of bizarre biochemistry and an unexpected anatomical finding requires careful correlation by our medical team. Notice the diagnostic breakthrough happening in the three columns here. The resident on the left points out a crucial biochemical signature. An insulin to C peptide molar ratio greater than 1 is highly characteristic of insulin autoimmune syndrome. They also urge an immediate biopsy of the breast lesion. The attending in the middle calculates that exact molar ratio to be a staggering 27 to 1. They agree to start prednisone to suppress the immune response, but only after a thorough infection screen. But the expert on the right lays down a golden rule. When you see very high insulin with detectable C peptide and negative pancreatic imaging, it is insulin autoimmune syndrome until proven otherwise. We just need the final specialized blood test to confirm this theory. Looking at the two panels on this screen, we have our definitive confirmation. In the serology panel on the left, the specialized blood test reveals insulin autoantibodies greater than 50 units per liter against a normal reference range of less than 0.4. This massive elevation officially confirms the diagnosis of insulin autoimmune syndrome. Meanwhile, the tissue panel on the right reveals the results of the breast biopsy. It shows invasive ductal carcinoma. Importantly, the histology report notes there are no neuroendocrine features in the tumor, meaning the breast cancer itself is not secreting insulin. We now have two highly significant confirmed diagnoses in our 85-year-old patient. Let us explore how these two distinct pathologies might actually be connected. Notice the final synthesis from our team in these three columns. The resident on the left suggests the newly discovered breast cancer may have acted as a systemic immune trigger for the insulin autoimmune syndrome. They emphasize tailoring the upcoming therapy to her functional status as an 85-year-old. The attending in the middle outlines the management plan, recommending a prednisone taper guided by antibody titers while fully staging the breast carcinoma. The expert on the right beautifully ties up the loose ends. The autoimmune syndrome is firmly established by the massive antibody levels, while the breast cancer perfectly explains her previously mysterious weight loss and constitutional decline. We are dealing with two parallel pathologies. Let us look at how the patient fared after treatment. As you can see in the management panel on the left, the patient was started on 60 milligrams of prednisone daily alongside a strict low carbohydrate diet to prevent massive insulin spikes. She also successfully underwent a mastectomy for her breast carcinoma, followed by a slow, carefully monitored taper of her prednisone. Moving to the right panel, her 1 year status is highly encouraging. She has experienced absolutely no further hypoglycemic episodes. Interestingly, her insulin autoantibody levels remain strongly positive, which is expected, but she is clinically well and asymptomatic at her follow up appointments. This excellent outcome highlights the importance of accurate diagnosis and targeted therapy. We can now extract some core teaching pearls from this complex case, starting with the fundamentals of hypoglycemia. Looking at the left panel, our first teaching pearl centers on the mandate of Whipple's triad. When you have symptoms, a documented low blood sugar, and resolution of symptoms upon administering glucose, you have proven hypoglycemia. At that exact moment, your evaluation must pivot immediately to identifying the underlying mechanism. The right panel details how to do that by capturing the critical sample. This must include plasma glucose, insulin, C-peptide, proinsulin, beta hydroxybutyrate, and a comprehensive drug screen. Crucially, as the text emphasizes, this blood must be drawn during the actual hypoglycemic event before administering treatment. Failing to get this sample leaves you guessing. Next, we will explore the specific mechanism that makes insulin autoimmune syndrome so uniquely dangerous. Notice the mechanism outlined in the left panel, which describes the reservoir effect. In this syndrome, autoantibodies bind to insulin immediately after a meal, rendering the insulin ineffective and causing temporary high blood sugar. However, these antibodies act as a reservoir, suddenly releasing massive amounts of active insulin randomly hours later, leading to profound and dangerous hypoglycemia. This explains her 45-minute post-dinner crashes. The right panel highlights the diagnostic signature of this phenomenon. Because the antibodies interfere with standard laboratory assays, the total insulin measured appears sky high. Consequently, the normal insulin to C peptide molar ratio is completely reversed, becoming greater than 1. Understanding this specific biochemical footprint is key to making the diagnosis. Let us review the overarching diagnostic evolution of this case. Looking at the 4 sequential boxes connected by arrows on this slide, you can clearly trace the evolution of our diagnostic reasoning. We started on the far left with a history of postprandial spells and weight loss, initially suspecting simple syncope. Moving to the second box, the emergency department captured the event, confirming Whipple's triad and forcing a pivot to endogenous hyperinsulinism. The third box shows the turning point. Bizarre biochemistry with sky-high insulin and negative imaging redirected our focus away from tumors and toward Hirata disease. Finally, in the fourth box, targeted serology and a tissue biopsy confirmed a dual pathology of insulin autoimmune syndrome and breast carcinoma. This brings us to our final reflections on clinical practice. Notice the core lessons divided into clinical and diagnostic categories on this final screen. On the clinical side, remember that strict postprandial timing is a major hallmark of insulin autoimmune syndrome. Furthermore, always keep in mind that elderly patients frequently harbor multiple significant coexisting pathologies, and you must treat the clinical symptoms of the patient rather than chasing an antibody titer. On the diagnostic side, the absolute priority is to capture critical blood samples early during an active event. Always calculate the exact insulin to C peptide molar ratio when numbers look disproportionate. Most importantly, anatomical imaging should only follow clear biochemical confirmation, preventing unnecessary procedures. Trust your metabolic data, verify your biochemical signatures, and always look for the hidden systemic